My name is Solveig Fadnes, and I'm a researcher at the Department of Circulation and Medical Imaging at NTNU in Trondheim in Norway. I would like to thank the organizing committee for the opportunity to talk about high frame rate imaging in pediatric and fetal medicine at this year's IUS. I will focus on the opportunities and challenges that I see in this field. The principles of parallel receive beamforming is the basis of high frame rate imaging, and those were introduced back in the 1970s, but it was not used practically then due to the limitations in the scanner's hardware. Now we've had an incredible development both with research systems and clinical scanners. With software beamforming and efficient GPU processing, we can handle much more data in real time and therefore also exploit the high frame rate imaging acquisitions in real time. In high frame rate imaging, we transmit plane or diverging beams covering the whole sector or a broad part of the sector, in contrast to conventional line-by-line imaging. With parallel receive beamforming, we can then form multiple image lines at once and achieve frame rates of several thousand frames per second. High frame rate imaging can be separated into two subgroups, roughly. Either we want to utilize the high acquisition rate to increase the information we put into one image, for example, compounding tilted images into a high resolution image. How many images we can compound depends on the application, but it's used to increase sensitivity and detection, for example, for transfusion imaging in the brain, which is shown here. The other option is to use high acquisition rates to investigate fast varying events for blood flow or shear wave imaging to evaluate tissue stiffness. In pediatric and fetal imaging, we've seen some examples of utilizing high acquisition rates for transfusion imaging. Here is an example of transfusion imaging in the neonatal brain, which we will hear more about in the next talk in this session. Newborns, and especially preterms, are in risk of brain damage in early life, and better tools for imaging and monitoring brain perfusion could therefore be useful to optimize treatment. High frame rate imaging has also been suggested to discriminate maternal and fetal blood flow within the placenta, as shown here in the image to the right. The placenta is one of the human body's most important organs, and yet it's one of the least understood. Its principal function is to supply the fetus, and in particular the fetal brain, with oxygen and nutrients. But the function of the placenta is not directly measured in any way during the pregnancy, only indirectly by estimating fetal growth and assessing Doppler measurements of the umbilical and uterine artery. Perhaps can high frame rate imaging give us the tools to increase our physiological knowledge of this amazing and important organ. Another example where high frame rate imaging can be used in pediatrics is with shear wave imaging to estimate liver stiffness. Tracking induced shear wave propagation in the liver at ultrafast frame rates above 1000 frames per second can be used to quantify the shear velocity, which is directly linked to the stiffness of the liver. In this study from Olivier Villemain from 2017, it was shown that the liver stiffness measurement is well correlated with the central venous pressure. The gold standard to measure this pressure is by right heart catheterization, an invasive procedure not suitable for close follow-up. A non-invasively estimate of the central venous pressure could, for example, help the physicians evaluate the effects of targeted medical therapy in pediatric patients with congenital heart disease. In cardiology, which I will focus on in this talk, high frame rate imaging has been mostly used to either look at the intracardiac blood flow or to investigate tissue characteristics. The intracardiac flow shown here is the inflow to the left ventricle of a healthy 2-month-old baby. Blood speckle is tracked over frames at several thousand frames per second to estimate the direction and the velocity of the blood. From the resulting vector field, we can display particle videos like the one shown here, where we can easily see a large central vortex which conserves the momentum of the blood flow and redirect the flow towards the outflow tract and the aorta. to the right, we see a high frame rate imaging recording with a frame rate of 4,000 frames per second. In red overlaid the B mode, mechanical waves that are naturally induced by valve closure or atrial contraction are seen propagating along the septum and the other heart walls. The velocities of these mechanical waves are directly linked to the stiffness of the cardiac wall. Looking closer at vector flow imaging in cardiology, there are different approaches to extract vector fields, as this one. Echo-PIV tracks speckle patterns from ultrasound contrast agents to resolve the vector velocity field. By injecting contrast agents, you boost the signal from the blood. Using contrast agents are, however, not preferred in all examinations, especially in children. In blood speckle tracking, you avoid the use of contrast agents and track the speckle pattern produced by the blood cells themselves. But with the low intensity of the backscattered echo from blood, and especially when transmitting with broad beams, sufficient clutter filtering is important to suppress the strong signal from the tissue and reveal the blood speckle. Alternatively to tracking the blood speckle, one can use a Doppler shift like in conventional Doppler imaging to get the axial velocity component, and together with the wall motion information, resolve the vector velocity field through regularization, which is the process in vector flow mapping. Both blood speckle tracking and vector flow mapping are available on clinical scanners, making it possible to do clinical studies to investigate the clinical potential of intracardiac flow estimation. So, let's see how intracardiac flow estimation can help the pediatric cardiologists. This is a patient needing regular follow-up with a pediatric cardiologist. It is a 7-year-old child with a single ventricle. This patient was born with just one functioning ventricle and had to undergo surgery after birth to make sure that the functioning ventricle is the one pumping the oxygen-rich blood to the body, while the deoxygenated blood returning from the body can bypass the heart and is redirected to the pulmonary arteries. The most important job of the heart is to pump oxygen-rich blood to the body, so we have to make sure that the functional ventricle is doing that. It is known that these patients can develop diastolic dysfunction, meaning that the filling of the heart is not normal. This should be identified as early as possible to apply appropriate preventive measures and prevent worsening of the condition. The hemodynamic variables that characterize diastolic function are the left ventricular relaxation, stiffness, and early diastolic recoil. And several echocardiographic measurements from B mode, Doppler, and tissue Doppler are used to evaluate the function by following the recommended flowchart like this. But this has been developed for adult cardiology and is not so suitable for children for different reasons like high heart rates, varying pre and after load depending on age, and the large variation in the heart anatomy due to different complex congenital heart defects like single ventricles. So then the question is if high frame rate ultrasound can help in this context. Because if we look at the hemodynamic variables we want to estimate, vector flow imaging can be used to estimate the early diastolic base to apex pressure difference that is connected to the left ventricle's relaxation and early diastolic recoil. And mechanical wave imaging has been suggested as a direct measurement of the stiffness of the heart muscle. Pressure differences are the driving force for blood flow, and being able to non-invasively estimate the base to apex pressure difference is therefore of high interest, and it's not a new idea. Color M-mode has previously demonstrated its utility for non-invasive estimation of base to apex pressure difference, also with encouraging validation towards invasive pressure measurements. Color M-mode, you could say that color M-mode also benefits from a high frame rate, it's just that it's just along a single line. And it's therefore suitable for measuring the interventricular pressure difference, as long as the flow is along the M-mode line. With blood speckle tracking, we're not limited to the the one-dimensional M-mode line and the axial velocities that is measured with M-mode. So how do we find the pressure difference? We utilize the Euler equation. So to go from velocities to pressure difference, we can use the Euler equation, which states that the instantaneous pressure gradients at a given spatial point is the net result of the change in velocity with time and the change in velocity with space. Integrating the pressure gradients along a streamlined path gives the pressure difference between the start and the end of the path. Particular pressure difference estimates based on blood speckle tracking was performed in an open chest porcine model. 2 micromanometer catheters were placed in the left ventricle by apical puncture. One catheter was positioned at the level of the mitral valve in the central inflow of the left ventricle and the other in the apex. Invasive measurements and ultrasound images were simultaneously acquired. Intraventricular pressure difference in early diastole from blood speckle tracking and invasive measurements from the same cycles were compared. Analysis from 103 recordings in 6 different peaks demonstrated a high level of agreement between intraventricular pressure difference from invasive measurements and blood speckle tracking without sign of proportional bias, as one can see in the Blunt-Altman plot to the left. The correlation between the non-invasive and invasive method was strong. This was very encouraging to try this parameter in the single ventricle case and compare with normals. So if we go forward with our single ventricle here, we have a normal heart to the left and a single ventricle to the right. And we compared pressure difference estimates from blood speckle tracking recordings of 95 controls to 27 single ventricles. And what we could see was that there was a significant lower intraventricular pressure difference in the single ventricles. The promising results do give hope that there is a place for high frame rate vector flow imaging in cardiology. So now let's move on to our smallest patient, because what about the unborn fetuses? Is it possible to make use of high frame rate imaging for the tiniest hearts? We don't have relevant acquisition setups for high frame rate imaging on clinical obstetric scanners yet, but we did a study back in 2017 where we used our Versonics research system to look at fetal data for intracardiac flow imaging. We included 10 women with healthy pregnancies and did high frame rate recordings in approximately week 20, 28 and 32. Even though week 20 is approximately halfway through the pregnancy, the heart is tiny, only 1.5 to 2 centimeters long. Throughout the pregnancy, as the fetus is growing, we could see that the heart was getting bigger, but still at week 32 it's only 3 centimeters long. The acquisition we set up was a packet acquisition with fully diverging beams covering the whole sector. We used no compounding for the flow imaging, but 22 beams in the packet for flow estimation. Even with the fully diverging waves, we got a good blood signal and could clearly see the vortex formation in the ventricles. Here we can see it for week 21, which is in this example, and we can see the inflow and the vortex forming on the right side. It's the same fetus at week 29 and 32, and in both cases we can see that the strong big vortex in the right ventricle. The blood pool is larger on the right side in fetal life, so it's easier to see more details in the flow pattern. In the example shown here, the apex is pointing upwards in all acquisitions, and the depth of the heart is approximately 5 cm. Across the 10 cases included in this study, the depth of the heart varied from 4 to 9 cm. We had the highest visibility to detect intracardiac vortices in the right ventricle in week 28. But we had the highest tracking quality in week 20. In week 32, we had problems with shadowing from ribs, legs, and arms. And you can also see artifacts in the video playing here to the right, which leads us straight over to the challenges that we have in high frame rates imaging. Challenge number 1, clutter filtering. Broad beams lead to substantially higher clutter levels, which influence both tissue and flow measurements. In this example, we have a single diverging wave, we have the unfiltered image to the left, and the data after clutter filtering with 2 different cutoff values for the clutter filter to the right, 6.6 cm per second and 13.1 cm per second. We can see that during the heart cycle, the tissue signal is getting through the clutter filter and heavily impacts the blood signal. It is most problematic when the valve opens. And a higher cutoff value can remove more of the tissue signal, but will at the same time attenuate parts of the blood signal. Clutter filtering is definitely still a field for research in blood flow imaging, and especially in the challenging case of cardiac and high frame rate imaging. Challenge number 2 is image quality and depth. With broad beams, we have a trade-off between temporal resolution and image quality. In this example, we have a high quality beam mode recording to the left and high frame rate recording from 4 compounded diverging waves to the right. We know that we get less signal back when we are sending broad beams, and the lateral resolution drastically falls. So we need to be careful to optimize our acquisition depending on the application and the given probe, and be aware of the limitations that exist. We still need both focused conventional imaging, but hopefully high frame rate imaging can give complementary information of clinical value in the future. Challenge number 3, finding robust quantitative measures. We can extract a lot of information from the vector velocity fields. Many different quantitative parameters have been proposed, like vortex propagation, vorticity, energy loss, kinetic energy, vector complexity, and intraventricular pressure difference. We have looked into applications for intraventricular pressure differences in this talk, but for a different application, one of the other parameters may be better suited. The experiences we do have from our different feasibility studies using blood speckle tracking for different groups of congenital heart disease is that one of the key challenges to making the quantitative analysis robust is standardization. Which leads us to challenge number 4. As long as we are in 2D, standardization of imaging views is important if we want to extract and compare quantitative measurements. Here is an example from a right ventricular 3-chamber view of a healthy 4-year-old. In this view, we have the right ventricle on top, and in an optimal view, we can see both the inflow to the ventricle and the outflow to the pulmonary artery. In the video, we nicely see both the inflow and the outflow, in addition to the vortex formation in the main chamber. In the panel below, we can see the average vorticity in the ventricle as a function of time. To the right, we have another example, also a healthy child at the same age. In this view, we do not seem to cut the ventricle in the middle, as we mostly see the inflow and parts of the outflow. Consequently, we can see that the corresponding average vorticity trace from this ventricle is lower and not comparable to the example to the left. In addition, we know that post-processing steps like spatial and temporal averaging affects the final estimates. And we need similar post-processing steps in studies where we are comparing quantitative measurements. With blood speckle tracking available for pediatric cardiologists in the clinical scanners around the world, actually, we are starting to see the user benefits of the new technology. Firstly, both patients and families coming for an ultrasound examination have given feedback that vector flow images are intuitive and easy to understand, which also makes it easier for the doctors to explain complex congenital heart disease to the patients and the families. The cardiologists we are working with can see the potential of the new techniques for early diagnosis, functional evaluation, and treatment planning. But for it to be an efficient tool in the clinic, we need bedside analysis and robust quantitative measurements. In addition to being a diagnostic tool, there is a potential for new insight into physiology and pathophysiology, and research in this field definitely gives a basis for further innovation. For the final remarks and future direction, I would like to first emphasize that echocardiography continuously benefits from technical development in the research community and the industry. The growing ability to handle large amounts of data simultaneously in the clinical scanners paves the way for implementing and testing high frame rate images techniques in clinical settings. It is a time for innovation. We have seen that vector flow imaging can improve the visualization and measurement of intracardiac flows, but the clinical value remains to be established. Several challenges still need our attention. The potential future research direction for high frame rate imaging in fetal and pediatric medicine are many, both within cardiology, like I focused on in my talk, and within brain circulation, like we will hear more about in the rest of the session, but also in other applications. In the future, I do think we will see more of 4D flow and utilizing AI tools at different stages of the post-processing chain, but perhaps particularly for quality control, automatic segmentation and timing, and thereby automatic quantitative measurements. With that, we can increase the workflow efficiency in fetal and pediatric ultrasound imaging. And behind all the work I've shown today, there is a big group, and I especially need to thank all the enthusiastic clinicians that we collaborate with that are more than happy to discuss potential projects, clinical needs, innovation potential, and that put down the effort and working hours to drive the research forward. That concludes my talk. Thank you for your attention.